not the entire one. So palliative care is through the cancer treatment, not just the end of the life treatment. Now come to the definition of the palliative care. WHO defined an approach that improves the quality of life of a patient and their family who is facing the problem associated with the life-threatening illness and the prevention and relief from suffering by means of early identification and assessment and treatment of the pain and other problems, physical, psychosocial, and also the spiritual one. So the definition includes the whole approach to make patient's life more comfortable. So the characteristic of the palliative care, what we are going to discuss about, provide relief of a pain and other distress symptoms. That is maybe the physical one or associated with the mental or some social issues. Affirm the life and regards the death as a normal process. It also integrates the psychosocial and spiritual aspect of care. Offer the support to help a patient to live the as active as possible life until the death. This is very important to understand. And is applicable early in the course of illness and conjugated with the other therapy that is also intended to prolong the life. So, what we understand the palliative care is, it is a specialized care to support patient and also the family who is going through the serious illness. The complex symptoms management through the oncology care, which include the supportive or palliative oncology, some surgeries, palliative radiotherapy or chemotherapy, and other treatments also. And include the symptom management in the early and also the advanced illness. Now, when the palliative care introduced in the India, introduction of the palliative care in India in mid-1980s, the first initial palliative care center was started in Gujarat Cancer Research Institute. In 1994, associated with the WHO, Indian Association of the Palliative Care has been established. But still, less than 3% of the cancer patients are accessible to the adequate pain relief or palliative care in India. So, we need more awareness and early involvement for the palliative care treatment. ESCO, the American Society of Oncology, also recommended that when we combine standard care, or the main focus can be make the patient life better. Earlier involvement of the patient care also lead to more appropriate referral and uses of the palliative care centers. And considered the early in the course of involvement, the illness, which combined with the oncological care, make the patient symptom burden less severe. Now let's proceed with the what are the common problems what we are going to face in the head and neck cancer. The first and foremost important is pain. The patient also many a time present with the pain only. The other problem is because it is head and neck, it aerodigestive tract. So dysphagia is another problem which are commonly encountered. And malnutrition is another one. Airway obstruction and retention of the secretion. Chemoradiation induced myositis, xerostomatitis is also can be seen. Now let's proceed for the pain, which is most commonly we see. Pain is considered the fifth vital sign of the symptoms. Now what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or maybe it's described as such damages. So if the patient says, I have a pain, then it must be evaluated. Right? So it is any unpleasant sensory or emotional experience we consider as a pain. Now, how to approach for the pain? When the patient comes with you with a complaint of pain, we should start from our basic assessment. That will help to differentiate between the pain types, and to treatment, many extent it depends upon the type of the pain. So if we identify the right kind of pain, the medicine which is going to work or the other intervention which is going to work on it will do the perfect thing. The approach to the pain management in head and neck cancer, first we go for the pain history. Like, the pain is chronic or is it recent origin? Are you taking any medicine for this pain? So, pain history, prior analgesic is used or not, history of any other chronic pain. And medical history is also important. Is there anything associated with the medical coordination? As we go further, good physical examination is also very important to differentiate the origin of the pain. So it is referred pain or it is from that particular area. And if we want to diagnostic any further evaluation, we can proceed for the imaginations or evaluations. For example, evaluation of any new metastatic disease, we will work further. The pain assessment, we say to OPQRST. Onset of the pain is also very important. It is sudden, gradual, or part is going on and off, or it is chronic. Anything which is provocating or palliative, movement, pressure, rest, or other external factors make the problem better or worse. We can discuss this with the patient and we can have some idea about the origin of the pain with this questionnaires. Like, sometimes while eating the food, full stomach is causing pain. Right? So we understand about it. Now, the most important questionnaires on the pain aspect is, pain is itself patient described in a different kind of words. It is very important to catch that words and know which kind of pain is it. Patient descriptions of the pain is, it is sharp, dull aching, crushing, burning, tearing. This word differentiate between the type of pain. We will come to know in the later stages. The pattern is constant, intermediate, or thrombing. So these questionnaires are to differentiate the type of pain, what patient is suffering from. The other question is also very important. Know the region of the pain or radiation of the pain. The pain is originating from which dermaton, or the distribution of the nerve, like facial pain, or the distribution of the through the trigeminal nerve. We understand which root is affected. And the severity of the pain. We have many assessment tools, questionnaires regarding this. The simplest one is, ask the patient about the severity of pain. It is mild, moderate, or severe. Or in the numerical scale, we can ask that 0 to 10. How much you can rate your pain in between? 0 is no pain, 10 is the worst pain. So patient usually rate the pain when they come to you in the first OPD. So you can score that it is something between 5 or 6 or 7. This is also important to get the follow-up. When the patient comes in the follow-up after your treatment or pharmacological and treatment, so we can assess that treatment is working on it or not. Or many a time patients say that I was comfortable at a time, but there are few phases of the pain when the pain is increasing. So with the severity scoring, we understand on the follow-up if the treatment is working or not, or maybe we evaluate for the disease also. And the other important thing is time. How long the pain been going on? Has it changed since its onset? Is there any increase in the pain which may alarm for the any other disease progress or any other issue too? So we should further evaluate it for regarding it. So onset, provocative or palliative, quality, radiation or region, severity and time. These are the very basic and important questionnaire to understand the type of pain. So these are the few charts available. You can access to it. The goal of our optimum pain management is, I am emphasizing on optimum because relieve the pain to the level that allow the quality of life that is acceptable to the patient. It is very important to understand and make patient and their relative to understand that the acceptable pain relief is what we want to achieve, right? During the progression or curative phase of the disease. Also parallelly, the risk and benefit is also explained to the quality of life. Now, pain we usually divided into the nociceptive pain and neuropathic pain. There were different pain pathways. So to understand this type of pain, it make more easier for us to go for the treatment. And with the questionnaires of OPQRST, we are able to understand which kind of pain the patient is suffering from. So nociceptive pain have two different kinds. This is somatic or visceral origin. Somatic is basically from the soft tissues and bone. Right? In the neuropathic pain, there may be damage or compression or infiltration of the nerve, some damage in the peripheral nerves. The other is damage or infiltration in the central nervous system, and the other important is sympathetically mediated pain. In this kind of pain, intervention will work very easily. So, nociceptive somatic pain, tissue injuries, inflammation are the common causes. The pain in character is a dull aching. Usually patient is as a dull aching. We cannot make a point in the thumb point that this is my area of pain. He always says it's a dull, idhar hai, udhar hai kind of. So in these areas, NSAIDs, opioids, and steroid for basically for the bone pain will work better. The nociceptive visceral pain is very poorly localized. Described as a pressure, cramp, squeezing, or colicky pains. So, the decompression of the causing tumor or other structures is important. Opioid will work good better, and sympathetic axial blocks. So basically in head and neck cancer, we always work the stellate ganglionic block will work better. So other type of the pain is neuropathic pain. Neuropathic, as we discussed about before, the neuropathic is due to some nerve injury, maybe nerve infiltration or irritation or any direct damage to the central nervous system. So nerve irritation or any abnormal somatosensory injury will lead to the neuropathic pain. The neuropathic pain symptoms are very particular. The patient will say it's a burning, shock-like, current or shock-like pain. So in this kind of the pain, the antidepressant like amitriptyline, tritiptyline, and SSRI, duloxetine, or gabapentin and pregabalin will work, anticonvulsant will work better. And the topical anesthetic agents are also going to work better on this. But this all are the temporary relief. And in this medicine, I usually describe my patient that take it for the long use. So after 2 to 3 weeks, the pain will start decreasing in its intensity. So we have to make ensure that patient will take medicine regularly. It's not like the other NSAIDs or opioid that after taking a medicine within 30-40 minutes or 1 hour, patient will get relief from the pain. So we have to ensure the patient that it will take some time. It is very important because many of the patient will take medicine for 3-4 days and then left over because it's not going to work. It's not working. So patient will discontinue medicine. So it is important to make them understand that it will take some time. Now, for the pharmacologically, treatment option for the pain management are pharmacological management. In pharmacological, we include non-opioid analgesics, opioids, and other adjuvant medicine. The adjuvant medicine are anticonvulsants, which we use gabapentin, pregabalin, and another antidepressant medicine like amitriptyline, triptyline we use for the adjuvant medicine. Psychological support, anesthetic procedures, and other neuropharmacological approach and physiotherapy is important part of treatment of the pain management. Now, WHO has recommended a pain ladder for the cancer patient. It's very important development in the pain. So, when patient presents with the pain, if the pain is persistently or increasing, we start with the non-opioid first and plus adjuvant as
Hello. Hello, you right? Hello? Kinjal, can you hear us again?
Yes.
Yeah, so I think you suddenly got disconnected in between. You can please start it. Restarting.
So can you help me to find which was the last, was able to hear me? Last.
Can you project your PowerPoint, please?
Sorry for the discontinuation. We'll start again with the treatment option of the pain management.
Sure, you can.
Am I audible?
Yeah, you are. You can please start.
Am I audible?
Yes, Kinjal, you're audible. You can please start again.
So we'll start with the pain treatment options. I think that portion we have discontinued.
Yes, you can start with pain management treatment options.
So there are different options for the pain management. We start with the pharmacological first. It is the one most important. We go for the non-opioid analgesic, opioids, and adjuvant medications also. The psychological support is also needed for the advancing disease patient and family also. Anesthetic procedures, interventions are also very good for the neuropathic and somatic pain. And also physiotherapy approach is important. Now the mainstay comes with the pharmacological. WHO has defined a pain relief ladder in 1984. It helps a lot to define the patient according to the pain and increase the doses of the medicines. So when patient comes with the pain and persistently and increasing, we start with the non-opioid things like tramadol and other medication with the adjuvant therapy. Adjuvant therapy, as we described earlier, anticonvulsant, antidepressant therapy. Then, in the second OPD, if the patient comes with a persistently increasing, which is mild to moderate pain, we start with the opioids, but the weak opioids. We come to know about the weak and strong opioid later. And always, the combination of the therapy will work better rather than taking a single medication. So, opioid and non-opioid combination is going to work better. And in the further progressing of the disease, the strong opioid with the adjunct of the other opioids or non-opioid is required. So with stage 1, 2, 3 according to the pain severity, mild, moderate and severe pain. In the pharmacological management, the non-opioid, acetaminophen and NSAIDs are usually used. Analgesic limited by their ceiling effect and most commonly this administered orally. Nowadays, diclofenac, ketorolac, patches are also available, which have a better role for the continued pain. The patient who is having continued blood leaking pain. The most common route is orally administration. The tolerance and physical dependency do not occur on it, which is the problem with the opioids. The mechanism of action is block the synthesis of the PGE2 peripheral sensitizers. 20 to 40% of the cancer pain obtain relief by these medications in a stage 1, which is mild pain. Move further. These are the doses and maximum doses with the half-life of the different drugs. According to the symptoms, we can prescribe the medicine, non-opioids medicine. Now move further for the opioids. So opioids are naturally semi-synthetic and synthetics. Natural opioids are morphine and codeine. We usually go for the morphine tablets and codeine tablets. The semi-synthetic have a better tolerance as in compared to the less side effect and potential is more. So methadone in the liquid form, which is better for the patient who is having oral limitation to give something. So liquid methadone is wonderful. Fentanyl is also available in tablet, patch, and IV forms. And the weak tramadol we can use. Other semi-synthetic are hydromorph, oxymorph, oxycodones are also available. As earlier I said, weak to strong opioids. We start with the weak opioids, and then as the pain further increases, we opt for the strong opioids. Buprenorphine is another wonderful drug available. It's also available in the sublingual forms. So, codeine, tramadol are the weaker ones, and morphine, oxycodone, methadone, according to their potency, we can use for their pain management. Opioid drugs are usually prototype of the morphine. The mechanism is they bind with the opioid receptor in a peripheral and central system. These are the centrally acting medicines which decrease the pain and pain sensation. So it is very important when to use central nervous system induced pain medications. There is no ceiling effect, but the tolerance and physical dependency is very important to understand. On the chronic use, we cannot acutely stop the medicine. We have to taper and see for the any withdrawal symptom is there or not. And simultaneously with the morphine and other opioids, we have to see for the overdose. Fatal complication, we have to check and even inform the patient about the doses. Many a time it happens that patient will take frequent medicine as it gives a pain relief, or maybe they accidentally take excess medicine. So we have to make them understand, the family or who is taking care of it. These are the medicine which cannot be taken in overdose, or these are the signs which is we expect if the overdose happens, you should inform your nearby physician or your doctor. Now, how to use opioid is the important thing to understand. It's a guideline. We understand one by one. First one is select the treatment tailored to individual case. So in cancer, there is not such a treatment which can be we make a protocol. Each and every individual is different. Each and every patient's symptoms are different. It also depends upon the age, their physical condition, the comorbidities which is associated with it. So select the treatment for individual patient according to their need and their condition. We always start with a lower dose and we can increase the dose according to the patient's requirement. The other second thing is start the specific drug for the specific type of pain. That initially we discussed is, if you only start opioids in neuropathic pain, it is not going to work. So to understand the type of pain, we require a vigorous and a definitive physical examination and questionnaires, what we discussed earlier. So once you understand the type of pain, it should be a specific treatment for the specific kind of pain. Third is administration the drug on the regular basis. Many a time patient take medicine as and when required. So I always inform my patient that if the pain threshold is on a increasing and you take oral medicine, it will usually take 30-40 minutes to reach the level to decrease the pain. Till the time the pain is on a peak. So you require 3-4 medicine to decrease the pain and the stress to the patient and relative or who is caregiving increase. So I always suggest take the medicine on a regular basis so the pain threshold is not going to increase. So regular interval medicine as doctor prescribed, I usually have a habit to write down the timing on the medicine. Like if I'm writing opioid, we'll take one opioid 8 a.m., take one opioid 1 p.m. So that make patient understand the interval of the taking medicine on the different phases. The fourth one is use combination of the drug. As we discussed earlier, combination of the drug will work better than a single or even strong analgesic. So always a combination drug will work better than a single opioid or non-opioid. Another important thing to make patient and the relative aware about anticipated and treatment side effects. Like what kind of side effect we are expecting. Many of patients have tremendous nausea, vomiting with the buprenorphine or tramadol. So if we have already informed the patient about it, and then the symptomatic treatment will start parallelly. So it will be easier to patient understand the analgesic effect as well as the side effect. Like sedation is a very commonly encountered in the opioid uses. Constipation is one thing which we should understand. We should make understand the patient, and treat according to. So parallelly, treatment of the side effect is also important for the competency of the patient to take medicine. Otherwise, many a time this patient refuse the I'm not going to take this medicine because I'm suffering for this side effect. If we counsel the patient earlier, it would be easier for them to understand the side effects and will continue the medicine with the symptomatic treatment also. Managing the tolerance is an important thing, and we have to adjust the dose according to the tolerance developed to the patients. Seventh is prevention and treatment of acute withdrawal. Opioid cannot be withdrawn acutely, otherwise we will see the symptoms. So make patient aware about it and treat the withdrawal symptoms is also an important to understand. And as we any anticipated complication we are expecting or not, there should be discussed with the patient. So this is the important guidelines to use opioids, because there is many taboos in our society to use opioid as a treatment purposes. Many a time patient asks me, do I will be addicted to the medicine or with the use of it? So they resist to take medicine. So it is important to discuss everything with the patient. So it is make more easier for them to take medicine and compatible with the treatment. So these are the other route of the opioids. We use orally. Parallelly, we can use the other route, like parenteral use. So transdermal patches are available, which is very good for the continue use. And many a time patient get, if I have to take medicine every 3-4 hourly, it gets more irritated. So fentanyl patches are available 12.5, 25, 50 microgram, depending upon the weight of the patient, because it is very important in the advanced disease. The weight of the patient is decreasing tremendously because of malnutrition or anything like that. So we have to titrate according to the weight of the patient, the opioid doses, so we can decrease the overdose side complications. Subcutaneous prefer over the IM. Subcutaneous fentanyl, alfentanyl, morphine are available. The another term what I want to discuss is breakthrough pain. What is breakthrough pain? So patient says that I am taking the medicine continuously, through pain is the persistent pain, and patient get a transient flare of the pain. In this, the different medicine can be used. So in your prescription, you should always prescribe a breakthrough pain. If the pain is more, you can take this medicine as informed to the caregiving or patient. At which kind of the medicine can be prescribed? Analgesic, which is having the rapid onset and the short duration of action. So buprenorphine tablets are available, which is very good for the breakthrough pains. Fentanyl is also available tablets in a 200 microgram doses. Intranasal spray is also available. We can move further with some anesthetic procedures. Now, only who require the procedures? Only 10 to 20% of the patient require the procedure, or in a very advanced stages, one who is not compatible with the side effect of the medicines. If you intervene timely and according to the symptom and severity, we can avoid these procedures, intervention procedures in the patient. So procedures patient required is most of the time nerve blocks and continuous intrathecal or dural infusion in a severe pain in case of advanced disease. Occipital, if the patient is having severe headache, occipital nerve block is and radiofrequency RF is a procedure of a choice. Many a time patient have a myofascial pains. The trigger point injection, trapezial injection are very common injections. Superficial cervical plexus block, we go for that. And as I told, in the advanced stages, we go for the continuous infusions, epidural or intrathecal. Now this is about the pain. We go further with the other complications. Palliative care include pain and other complications too. So malnutrition is another common complication, and malnutrition in the head and neck cancer is due to many important causes like patient even nausea, vomiting, poor appetite, difficulty in swallowing or chewing is the very common, and pain or dryness during the swallowing is because of the ulcers in the mouth or throat. So malnutrition is basically because of decreased oral intake, pain or dysphagia. Ataxia is because of some cytokine release because of the tumor progression. We always assess for the nutritional values with the dietitian, and supportive fortified food can be added with the oral supplements. If the patient is not able to take orally, we can always opt for the enteral tube, nasogastric tube or jejunostomy, depend upon the patient's condition. In head and neck cancer, we don't require parenteral nutrition frequently as compared to any other GI tract tumors. These are the common causes of the malnutrition. Cancer-related fatigue or cachexia is very common. Other is respiratory tract infection, secretions. Due to the activation, this is commonly I have seen with the radiation induced in the patients who are taking the radiation. So manage the secretion with the hyoscyamine glycopyrrolate or transdermal hyoscine is a very good option as an anti-secretory. Myositis and xerostomitis is commonly with the chemo-radiation induced injuries. As patient is going to take 30 or 33 radiation, frequently this myositis is very common, which is present because it is troublesome to continuous taking food, water or anything. It is very painful, therefore it comes first. Painful and can be interfere with the food intake. So it leads to malnutrition, decreased weight. Symptomatic management, oral hygiene is very important. So maintain the oral hygiene. And we can start with the NSAID. In the severe cases, these are the WHO defined the mucositis. First is soreness or erythema, is a grade 1. Arrhythmias with the ulcer. but patient can swallow the food. That is grade 2. These are the patient which we can manage with the topical treatments. But patient with the severe mucositis, ulcers with the extensive edema, which is making patient not to take food, or it is very painful. So local anesthetic lignocaine is partly used, but patient complain when even I'm having my take my water, it is very difficult for me to take water. So in these cases, we can start with the weak opioids and mucositis with extended. This is always an indication that we can start with the weak to strong opioid, and till the time patient's ulcer are going to heal, we will continue and then slowly we taper. So in our institute, it is very frequently I encounter that during the radiation treatment, we start with the opioids, and slowly after the treatment, 2 to 3 weeks, we taper and stop the opioids. It makes patient more comfortable, and the most difficult part during this treatment is to make patient counsel and aware about this is not your end stage of disease, because in our scenario in India, this is if you're taking morphine or any other opioid, this is your end stage disease. It's a taboo in our society. So first I counsel the patient that this is just to make you more comfortable and continue the treatment till it complete and recover it. Xerostomia is another commonly encountered complication with the radiation. The patient complain about dryness and increased chest, mouth burning. So at a dose above 52 guys, it's very common and irreversible. So we treat according to it. Terminal hemorrhage, it's a caregiving and a homestay patient also. So another part I want to emphasize is, apart from the pharmacological, like patient physical symptoms, I have seen very common the depression in the head and neck patient who is undergoing radiotherapy. So the depression in the radiotherapy prediction, the pre-radiotherapy depression is present. Patient is less than 50 or 55 age, because they have so many social liabilities. So the fear of death is always been lead to the psychological involvement in the young patients. One who is single, not having any caretakers, living alone, or working priorly to onset of the therapy. So depression is one we have to look for the patient with the RT. So many a time, because the surgery and recovery take 5 to 6 days, and within a 2 to 3 months it will recover by food. But radiotherapy is taking long time. Daily visiting to hospital for the radiotherapy make patient more psychologically disabled rather than having a physical symptoms. So psychological support or medicine also needed in this patients. So this is depression score for the head and neck patient. So at the end of the lecture, we summarize the things. Component of the good death is control the pain and physical symptoms, clear decision making by a knowledgeable physician, so who can make the patient and relative understand about the drug use, the effect, and as well as the side effect what we are anticipating. Empowering the patient and then relative, the reduce fear and knowing what we are expecting. If the disease progress, these things we are expecting. If we explain the patient or relative, it would be very helpful for them to understand and decrease. The most important is decrease frequent emergency visits. because patient and their relative become so apprehensive that because of some sudden onset of complication, they rush to the ER. So to make them aware about it and knowing what we are expecting, they understand and do act appropriate. Appreciate the importance of the meaningful of the end of the life and the time with the family. So the palliative care is not only end of the life, but it also through the assistant end of the life care. So we can always bring enter earlier palliative care in the earlier stage of disease. Palliative care is not give up on the patient. It's an excellent evidence-based medical treatment. Vigorous care of the pain and symptom throughout the illness is needed, not the end of the stage only. Care that patient want at the same time as effort to cure or prolong the life. Right? And as I discussed earlier, it is not the same as hospice. Hospice is the end of the life care. Palliative care we always can take parallelly with the oncological treatments like palliative surgeries, palliative chemo, palliative radiations are very commonly seen. Thank you.
Dr. Kinjal, thank you very much. Lovely talk. I thoroughly enjoyed, and it's very important for students to understand it is not just about cutting, operating, giving chemo, and that is a minuscule part of the oncology treatment. Cancer counseling, pain management, palliative care, and then taking them through the end of the life care, hospice. These are the most important component. In fact, that is what really matters only to the patient and family. Even though we give a lot of importance to surgery, chemo, radiation, which are minuscule part in the overall well-being of the cancer patients. You emphasize it so well. Thank you very much. There are some questions in the chat box and Q&A. Dr. Dushyant and you, if you can coordinate and answer them. Thank you.
Yeah, sure.
Kinjal?
Yes.
Yeah. So I think very well-rounded lecture, and we actually use a very minimal part of pain and palliative care in our practice day to day, most of us, and you have elaborated it nicely. One personal observation and question which I have, I think we can start with that, is that when we put patients for pain management, what happens is that patients get symptomatically better. They do their own dose adjustment. They even switch over the medicines because general physicians around them are not aware of the pain management protocols. So they guide or misguide them, and that entire management goes haywire. And they come back to us again, and then we send them to you back again, and that's a perpetual cycle. So actually, they don't get a real pain management. So, what is your advice, and how it should be managed, and how the patient should be educated regarding that?
So, as we all focus on pharmacological and as a pain physician on the interventions, I would always suggest counseling is a first part of our treatment. So, as in the lecture also I emphasize on it. I usually make patient aware about the medicine use, their side effects, and anticipated complications. And in case if you have breakthrough pain, so these are the medications. So prescription always be in a very detailed and as in our hospital we have established a pain and palliative care department. So it would be helpful for the patient if they have any kind of complications or any kind of problem, they can approach to us. So by the spreading the means of educating the patient about the things, it would be helpful for them
Looks like she lost a network. Dushyant, you can take over and answer all of them.
Yeah, I think she has some network problems. And so Kinjal was actually answering my question, but I would like to elaborate on that. That the pain management part is not kind of a part where you have appointments and then they are managed. It's a continuous process. So your pain management specialist needs to be with you, with the patient, continuously interacting and guiding them rather than meeting them once or twice in a month or something like that at intervals. So the consultation with the pain specialist basically depends upon how well the pain is managed and how it is treated, and it should be continuous rather than intervening in between. Rather, we as a clinician should also avoid prescribing pain medicines while pain management specialist is on the board, to actually not to mix too many agents at the same time.
As I explained that to understand the type of pain is more important than the anything else. So if you prescribe right drug for the right kind of pain, in the lecture while I'm also described, if you're in the neuropathic pain, the highest dose of morphine is not going to work. This is the one thing I'm very sure about it. So I explain the things like that only. And from our side, it is our duty to inform, because in every city, the pain physician is not available. So educating the caregivers or the doctors who is working with the oncology, the right kind of medicine should be prescribed on the right kind of the type of the pain. It is more important to decrease the pain. So NSAIDs there's a different role. They have a different pathways. Opioids have their different pathways. So we should always be very vigilant about when the patient gives history. It is very important to listen it carefully, because they always say what they feel. So in the definition of the pain, so the definition of the pain is any unpleasant, whether it's a pathological or not. You have to understand that. So by understanding the symptom, you always be concluded that this kind of the pain is that, and I should do further with this kind of the treatment will work better for the patient. So it is important to understand the pain. In the general practitioner, it is commonly happening that they put the cocktail and then patient encounter because every medicine is going to give some side effect or something. So putting a right choice of drug would lead to the less damage to the patient.
Yeah, we have one question in the chat box, and you have in a bit elaborated about that. Is that patient is not responding to even morphine in combination? I think it is cocktail the student is talking about. What should be the next treatment plan?
So if the patient, then the 10 to 20% what I have explained about it, the patient who is not responding to the pharmacological treatment, we should always go for the intervention. In intervention also, I want to say one thing. The counseling is very important. The cancer patient is so much disappointed with the pain that they want something which can relieve everything. So I used the word optimize and adequate pain relief. So I always say to my patient that we cannot come to the zero score. But yeah, my duty is to make them more comfortable, make their life more comfortable. So the one who is not responding to the cocktail, the first criteria is to just go through the symptoms again. If we are not wrong on the medicine, the first thing we have to correct. And if it is not working, then you opt for the intervention procedures and explain that with this procedure, we can optimize this that much of the pain or symptoms, and for the further we require medicine also. This is very important to discuss with the patient. Okay, after the treatment, after the intervention, we are also going to continue few medications.
Yes, Kinjal, there is one more question in the chat box, that is, IV morphine is safe to give or not, and what are the indication and dosages of IV morphine?
IV morphine in the hospital area, we can opt for it. But I think fentanyl is a better option, as the potency is also well, and the safety, like respiratory, because most of when we are going to prescribe IV, that is end of the life treatment, right? So it is better to these are the medicine which is better to give under the vigilance in the hospital. So fentanyl is better option to opt for the pain relief. And if we can combine, if the patient with the who don't want to admit, nasal midazolam are also available. So I would suggest morphine. Rather than taking morphine, we should always opt for the fentanyl. And the doses, the loading dose, according to as the patient is maybe malnutrition. So according to the weight, the doses is 1 microgram per kg in the 10 to 20 over the 10 to 20 minutes. We can go give the bolus, and then we can continue the 0.25 to 0.5 microgram continuous infusion, but it should be under the hospital and with the continuous monitoring.
So I think there are no more questions in the chat box now, and you have very well explained the entire pain management protocol, and it is so important, and it's kind of a boon to have a pain specialist with you from the beginning of the treatment of the patient, and it guides you throughout the treatment plan. As an oncologist, it is very important for us to manage pain, and when the pain specialist is around, it gives a lot of comfort to the patient as well as to the treating physician. So thank you, Kinjal, for this, and over to NBE. Thank you.
Yeah, Kinjal, thank you very much. Lovely talk. Wholehearted thanks from my side and NBE board and the students.
Thank you, sir. Thank you.
Thank you very much. So over to you, Amitji.
Thank you, attendees and faculty members, for joining the session. Thank you, sir and ma'am.